Thanks, Katy.
Yeah, and thanks, Nikki, for doing the slides. Yeah, I'm going to talk a bit about research opportunities and pathways for people in health and social care. As Natasha said, I am a social worker, and so a lot of my stuff lends itself more to social work, but I will include health and social care as well. I'm a social work research lead here at Lancashire and South Cumbria Foundation Trust. Also an NIHR, National Institute for Health and Care Research, pre-doctoral fellow, which I'll explain a bit more about in a little while, and the Regional Research Delivery Network, the community settings lead for the Northwest, again with the NIHR, and I'll explain a little bit more about that as well. I am on LinkedIn, and that's my email address if anyone wants to get in touch at a later point. Do we go to the next one? Thank you. So this is my journey, and it's just to share it and I suppose see whether it's useful for anyone else to think about sort of research and background. So initially, before I was a social worker, I worked as a prison officer for a few years and then moved into to become a substance misuse worker, but to set up a service for children aged 15 to 18 in prisons to look at recovery from their substance misuse, harm reduction and education. And that came off the back of some research evidence that actually what we provided in jails was very adult focused. We were looking at withdrawals from heroin, alcohol as well, and what children were using in terms of substances were quite different from what adults were using. So their main focus was cannabis, alcohol and steroids. We did have people that were needing detox from other things, but what we needed was something that fit better. So the 14 children's estates all came up with a new way of working. So it was the young person substance misuse service, and collectively across the country we looked at creating resources that were child friendly and co-produced. Then I went back to uni and became, well, I did a bit of community substance misuse for a while as well, actually, and working with a whole family approach around parents' drug and alcohol use. And then I retrained and became a social worker and worked in adult mental health social care before moving on to being the adult mental health social worker within adult mental health practitioner, sorry, within the children's family safeguarding service, so the whole family approach there, and becoming an AMP, an approved mental health professional. And I have actually noticed one of my first line managers from being a social worker is on today, Amma, so it's nice to see you there in the crowd. Not seen you for a while. So from there, while I was working for this trust, because I worked for Lancashire County Council and moved across to LSCFT, there was an opportunity to do some small scale practitioner research. And honestly, when I heard the word research, I thought, oh my God, boring. Like, it's like going back to uni again. I don't want to sit, I don't want to read stuff. Journal articles are not for me, they're really complex. But then my service manager at the time said, come on, why don't you do this? And because I really liked her and respected her, I thought, oh, go on, I'll give it a go. And at the time, the practitioner research was led by a professor of social work and a doctor in social work. And it was really good, actually. It was 6 months of focusing on what I wanted to focus on, how we could make a change. So I looked at the family safeguarding service, which had been going for a year, and what the impact was of having adults, oh, thanks, Emma, of having adults practitioners based within the family safeguarding service, so having mental health, domestic abuse perpetrator and victim workers and substance misuse, and what the impact was of having those involved in terms of working together as a whole family. And from being able to do that, I got to go out and interview people and collect what I've got and analyse it. And that bit was really interesting because as a social worker, I want to go out to talk to people. I want to find out what people think. I'm interested in how that works. And then writing that up, it didn't have to be a big complicated journal. It was about how is this going to help and how is this going to change for the people that we're working with. So this felt relevant to me as somebody in social work. And actually we did make some service improvements. So we were able to create a pathway for promotion and career development that didn't exist before. So that has helped more people to stay within that service because they can see, you know, there is some longevity in it. They don't have to leave to progress their career, but also it increased the capacity for psychological therapies, which help the families then because they could access them more quickly. So From there, the NHR have some really, really good schemes that you can apply for. And my current boss applied through the School of Social Care Research for some money to build capacity for social workers, because our social workers here at Lancashire and South Cumbria are quite a minority in terms of the health colleagues. So we have a clinical research and development team, which is focused on recruiting people to clinical trials, which is really, really important, because actually if we don't get a breadth of people in clinical trials, we can't come up with evidence for things like new medication and treatment. But it isn't very social worky, it's very health. And we have about 260 social workers here, so we're kind of the largest employer outside of local authorities. But our social workers are very detached from research, as are lots of social care workers. So my role was created as a social work research lead, and really my role was about how can we build capacity, how can we make research seem current and exciting and relevant for what people are doing, how can we align it to what people's existing skills are, and how can we create research that's qualitative, because like I said, there's lots of quantitative, like RCTs, clinical trials, things like that, which, yeah, great, you're getting loads and loads of people through the door. But what we're not getting in general is people whose voices are quite hidden within research. So NHS England then funded the 42 ICBs in England to do research engagement activities to increase community members and people unheard in research to be involved in research, and kind of came back off the COVID-19 testing and implementation of vaccines and things, that actually the people that we have in our pool of volunteers to be involved in research are often white, middle class, middle-aged people, and that's not helpful for when we're trying to look at how does this affect somebody from a global minoritized background, how does this affect somebody who has a disability in some way. So we need to increase the bank of people that are involved, and by doing that, it's not about going out and saying, right, I think you should come and do this. It's about really getting people to own, control research, but also that flow of information and saying to research deliverers and funders, this is what's missing, and that if you're not meeting the communities where they're at, you're unable or unlikely to be able to pull them in. So off doing some of that work, and I think we've done 15 programmes with different community members and right across Lancashire, South Cumbria. We've worked with refugees and asylum seekers, young homeless people, parents who were substance users, young autistic people, parents and carers for disabled people, deaf people, absolutely loads. And all of those have gone on to have some involvement in research in some way. So whether they're a recruitment site, whether they're advocating for people in their communities, or whether they're looking to do research in their own right. So from there, the regional research delivery network was restructuring, and there was an opportunity to become a community settings lead. So 2 days a month, I am the community settings lead, and that covers pretty much everything that's outside of a hospital setting. And again, that's very much where the NHR's thinking was. They recruited people from hospital settings, but people don't live in hospitals. So community covers all what we think of communities, like all of us that live out in the community, and we do link in with a bit of primary care as well. I don't cover things like care homes and prisons. So although we have a social care speciality lead, I work quite closely with him. I'm not the social care speciality, but of course my work sort of feeds into that because that's my professional background. So I learned quite a lot about the NHR, and what is interesting and what we don't tend to know in community working is that there is quite a bit of money for career development and for grants and things. And until you've been introduced to them, you don't know about that. So I applied for a pre-doctoral fellowship, which funds you entirely for your wages, for either 100% for full-time, or you can do it part-time. So you're essentially bought out of your job. So I'm still employed by the NHS, but the NHR pay for everything for me, and all your on costs, your national insurance, pension, and everything. And you create a career development programme. So although I already had a master's, it was in social work, which wasn't like really relevant to, although the skills are relevant, the knowledge around research and methodology and methods was not as good. So I asked for a master's in research in health and social care. I also asked for an NHS leadership programme because in the future I hope to be able to do more grants and things. So you need to know how to lead a team, and you also have time to make a doctoral application. I pulled together an advisory panel made up of really, really different things, or really, really different people, should I say. So my research area of interest is mothers with the diagnosis of personality disorder or complex, or complex post-traumatic stress disorder who have had children removed through the courts. So my advisory panel is made up of foster carers, adoptive parents, children who have been fostered or adopted, people who have a diagnosis of either of those things, who've had children adopted, principal social workers, mental health specialists. So it's a really good range of people who've advised me so far to create the doctoral application, but who will continue to advise if I am awarded the money for the next 3 years while I did a PhD. I've also been able to go to lots and lots of different conferences. So a couple of weeks ago, I was at the European Social Work Research Conference presenting on some of the co-production work we've done with communities. And that meant that me, a professor in social work who's obviously linked to universities, and a community member could go and talk about how our work leads in and how we've co-produced. And part of this pre-doctoral fellowship is to continue to go to those conferences for networking, but also to share the work we're doing so that it's disseminated in the best place. So sometimes that's conferences where academics are, and sometimes it's areas like bits of training that actually practitioners are going to go to. So there's some of the learning there, and I can have time on placements and the travel to those placements to work with some of the voluntary agencies who essentially are going to advise me and potentially recruit into my study if I'm successful in getting that. Thanks, Nikki. Glad to know I'm not as rambly on the next slides. Just a bit of scene setting there. So looking at social work and social care and the health interface, and I touched on that a little bit before, we have really good infrastructure in this country for research within health settings. So this is just what, when I asked, how to, I think it was it Copilot, someone to throw up some images of what this looks like. So in health settings, often you can go into, if you're in a hospital, there's lots of signs up saying, would you like to be part of this trial? Or people may offer you, there's a new potential treatment pathway. You may be allocated to normal treatment or to the new pathway, and you wouldn't know, but at the end of it, we'll follow up and we'll see if there's any evidence to say the new treatment pathway is better. So you've got a 50-50 chance of receiving that new model of care, but also for informing things for the future. So there is, and like health are very embedded. So the National Institute for Health and Care Research, the acronym is still NIHR. So the focus is still on health. But when we think about the range of health, as I mentioned earlier, it doesn't just happen in hospitals. There's lots of things in primary care. There's the things about being health as in well health, not just ill health. In mental health, we have services that are about kind of secondary services around treating people with mental ill health, but we also have lots, particularly in the third sector, about maintaining and improving people's mental health or emotional health. We have things like people with different disabilities, the hidden disabilities, the disabilities we can see, lots of other social issues that are out there, isolation, loneliness. So there's an awful lot of people thinking about home care workers that are going in and working with people who, and because of the nature of, there are more difficulties reaching of them, like, there's lots of different private care agencies. So there's not one place to say, actually, here you go, you could then offer this to people in their own homes or in care homes. And then we have things that sometimes research shies away from. So if you've got someone with an intellectual disability, or if you've got somebody who has dementia and we're thinking about their ability to sign up for trials, it's often more difficult than saying to somebody who hasn't got any of that impairment, would you like to sign up, yes or no? But there are lots of ways to maximise someone's independence and choice so that they can still sign up should they wish to. And with some of that may, as I said before, mean that they get better or different treatment, which may improve their quality of life as well. So it is a real big push to how can we get this embedded into social work? How can we get this embedded into social care? And by very nature, social workers work closely with social care workers. And how can we create some knowledge ourselves so that we're able to sort of sell it in the best possible way? And that sounds awful, like, we're selling something and we're trying to persuade people into things. But I suppose really understanding what are the benefits for the people we work with, because we work in these environments and in these roles because we want to improve quality of life for other people, and how do we move this more out of hospital care into actually preventative care, into keeping people well, into people's own communities. Because when someone's community understands something, you're more likely to recommend it. If I've watched something good on the telly, I'll say to my mate, oh, have you seen this on Netflix? And then, we pass it on and stuff. We're influential within our own communities, aren't we? And it's much stronger when a community takes something on and runs forward with it than what it is when a health worker's saying it. And plus, health workers have really finite amounts of time with people, so we're not always able to offer it. And social workers also have finite amounts of time, but generally we have more time for conversations than somebody going in for a hospital appointment or a GP appointment. So we're in a really good position to be thinking outside the box for people. And things like taking part in research actually can cure some of that isolation and hopelessness that we see with people. So again, it's another good way of, if we can promote stuff where people can be genuinely involved and empowered, that can help people's trajectory and recovery as well. Next one, please. So why should we be doing research in frontline practice? And again, I've kind of touched a little bit on it, but we are connected to the consumers. So whether you want to use the word patients or service users or residents, the people who are using any sort of services, which includes us as well, we are connected to them in our professional roles. So by creating recruitment pathways, it's more powerful than putting something up on a wall in a hospital. Be Part of Research is on the NHS app. So if people are on the app, it sort of says, oh, why don't you sign up? And I'm not very popular in my opinion for saying this, but it's not a good system. You will sign up to it, and then there's loads of it's not even a tick box. It's like, name what you're interested in. So you might think, oh, I'm interested in mental health, social care, but you might also have different interests, but because it's not in your head at that time, you don't put it on. So it's a poor way of recruiting people. Whereas if we're speaking to people and saying, why is it important to you? So if we're talking to women, for example, why is it important that you're part of it? Well, when we go back in history, aspirin was tested on men. So we are giving pain relief or, blood thinning relief based on what works for men. So our health as women is put secondary. And again, we're looking at other things like people with learning disabilities die, they've got a shorter average lifespan than people without. When we look at people with learning disabilities who are also from a global minoritized background, their life expectancy is roughly half than those who are white backgrounds. That is not coincidence. There's something going on there around a health inequality. So by working with people and saying, this is really important that you are involved in this stuff, you might not make changes for you immediately, but you are making changes for other people in your position, because we shouldn't have a different lifespan because of somebody's heritage. We shouldn't have a different lifespan or a higher mortality rate because you are not white, not English, and you're going through maternity care. And we know that these all exist. You shouldn't have a lower lifespan because you are deaf and you're not able to access some aspects of things. So as we're going in there to people, we are in a position to create recruitment pathways. We are in a position to be able to feed that back up to commissioners of research and say, this is what the barriers are. We understand those needs and challenges. And although people often see social workers, and again, looking at social care, I'm aware there's other people in here that are not just social workers. Actually, when we're going out seeing people in the community, we build trust with people. People trust in us. And we can embed that change if we're able to create recruitment pathways through understanding of the benefits of research and what's out there. We are then able to get that into our communities. And the ultimate outcome is the improved quality of services for people, which is really, really important, and also the increased equity for people, because at the minute it's very, very unequal, unequitable. And also we do have a healthcare infrastructure within communities. It's not just about out of hospital care, it is about the wider range of what is in community, what health promotion is in communities as well. Next slide, please. Okay, so why health or social care research? I've covered most of this, but social workers and social care workers really underserved in research. We are not as involved at all. So it's a good opportunity to get involved. You know, we don't identify as academics. However, we've got lots and lots of skills there, and we do have opportunities to get things out. We can write things that are out there, whether that be presentations, whether that be blog pieces, whether that be academic journal pieces. We can share that information with people, and we can make a change. People employed in local authorities often can't get hold of academic journals. So if we're outside of a university or outside of a local authority, we don't have a library service that gets us in there, which is a real problem as well. NHS tends to have access to library services, but even when we have access to journals, it's about when do we have time to read them? Does it make any sense for us to read those things? Because personally, I'm working in research and I look at something like a complex methodology or results section, and I really have to, you know, that's part of doing this master's, to be able to break it down and understand it. When I was in frontline practice, I wouldn't have the time to be able to do that. If it's too complex, we can't get on and do that. Our communities are really excluded from research, and as I've said earlier on, you know, it's about we're embedded in communities. We can make that change. We don't want research happening just in universities, because that doesn't create practice change. There's a, you know, there's a big disconnect between. So we need this to happen within communities. We need to make change from within. And right now we're in a good position because funders like the NHR really want to reach us in social care and social work. So we're in a good position to gain funding and be able to do that at the moment. Thank you. Next one. These next two, I'm just going to flip through. This is if you ever want to look at it, but just to give you a flavour of it, the NIHR Regional Research Delivery Network, we have 4 settings leads: hospital settings lead, community, which is me, residential setting lead, and a primary care lead. And then within that, and there's one for each area, so this is the Northwest one, there are 29 different specialities, and you can see the social care is one of them, mental health is one of them. These are all things that happen within communities, not just within hospitals. So if you've got an area that you might be interested in, and it'll feed nicely into the next presentation, you know, the specialities and all of them. I think next one's the last one, please, Nikki. So this is, again, something you can take away with you. There's no point me going through all these links at the minute, but this is opportunities that you can get involved in. So I have a research distribution list. Anything that comes into me, I send out to all those people, and it comes in from health, from social care, and from social work. So if you want to be on that list, just drop me an email and I'll add you. There are different communities of practice, and that's a bit ad hoc, just finding out what's going on in your local community. The Non-Medical Research Forum runs once a month on a Friday, and there's a link there. You just click, fill your details in, and you can be part of that. We offer a social work research and practice development forum every other month, and Katrina, who's my backfill currently, that's her email address if you want access. Most local authorities now have a local authority research practitioner, so if you're in a local authority, find out who that is. And there's also a local authority research forum, which you can come to me if you want to know how to get access to that. There's just some links about newsletters that you might want to sign up for, different training and internship opportunities, and then the NHR that offers career development opportunities within different levels. So all the information for them are on the website, and the website links are there, but the insight is about getting into research, maybe doing a master's in research. Pre-application support funds, the fund to help buy you out your time while you write some of these applications. We've got short placement awards for research collaboration for local authority, the pre-doctoral award that I'm on at the minute, the doctoral, which is 3 years full-time or 6 years part-time or anything in between. Again, it's buying you out of your role to be able to do that. Postdoctoral research if you've already got a PhD, and then the research support service, who we're going to talk to you next, and they're from the Specialist Centre for Social Care. I'm sure that's me done, Nikki.